Down. And good afternoon, CNY Nation. I'm Dr. Randy Fink from CNY Fertility in Colorado Springs, alongside of the incomparable Dr. Robert Kiltz from CNY Fertility in Syracuse. Now, you may say, Dr. Fink, if you are from Colorado Springs, how are you sitting next to Dr. Kiltz?
The magic and miracle of mirrors.
Mirror and the internet.
Yes.
Mirrors and the internet. Well, this is quite an auspicious occasion to be here today, and we're so glad that you were all able to join us. Hopefully you'll be joining in, but I say it's auspicious because it's someone's birthday. Who could that be?
Tomorrow.
It's nearly a
it's
birthday.
Close.
It's the birthday weekend. Hi, Hannah, and hi, Melissa. Glad to have you with us. And I'm sure you're joining in order to be able to celebrate Dr. Kiltz's birthday, as we all are, right? Ariel, glad to have you here. So, in the last few weeks when we've gotten together on Thursdays, we've talked about some interesting things. We've talked about keto diet. We have talked about moods and depression. We talked about some important topics, things like suicide and how to deal with things in the fertility world when they all go wrong. And today I thought might be a good opportunity, since we're sitting side by side, to really see. Thank you, Bridget. Happy birthday.
Happy birthday. Thank you, everyone, by the way. And Kaylee, hello, Rhonda. Thank you very much. Bridget, Gabrielle, Lena. Oh, yeah. Amy, oh my God, Amy, I feel so blessed Lena, with the amazing family.
See there. Yes, indeed. I thought it might be a great opportunity to kind of just field some questions and answers about fertility, which is the stuff that we do day in and day out, and really the reason that you've joined us. So if you've got some questions, now's a good time to throw them in here through the comments. We'll be able to read them and hopefully give you some nice and helpful feedback on things. And, while we're starting the topic, what else better when you start a topic is, when the fertility evaluation. The feedback I've gotten from folks is that one of the least favorite things to have done, the least favorite test is, let me see, are you reading my mind? The HSG.
The dye test,
the
right?
Dye test,
which basically is you're going to die from doing this test, which is apropos in so many ways, as they say. But at CNY Fertility, when we do it, there's almost no discomfort. And I would say because you have to go really slow and easy, and you inject the contrast very slowly. But the amazing part about doing that test is quite often helps people suddenly conceive naturally. That's the amazing part of the story.
How does that happen?
Well, let's see. What do I talk about incessantly all the time?
Diet,
keto,
inflammation.
And it was interesting today. So I spent all day in the operating room at Krause Physician Office Building, taking out uterine fibroids and scar tissue, which is all related to inflammation. And I went over to the post-operative area to talk to one of my patients, but it wasn't one of my patients. It turned out to be someone that had just had a miscarriage in a D&C that I hadn't met before. But she said, "Oh, Dr. Kiltz, I got pregnant because of your diet, keto. But once she was pregnant, she stopped keto. When you're pregnant, stay keto. It's so critical and important." So that's one of the things that I've learned, that when you reduce the inflammation, whatever you did to get there, stay doing it, okay? It's really important.
Hey, speaking of that myomectomy, Melissa asks, how long after a myomectomy before a transfer?
I recommend at least 3 months and sometimes up to 6 months. I don't think you need to wait longer than that. You need to allow the uterus, the scar tissue, it to heal up properly so it has integrity, that once you conceive and the uterus stretches, it's not going to break open. And critical is important. If you had a significant fibroids removed, you're going to need a cesarean section, and it should be done before you go into labor, and certainly by term is what we generally recommend.
Typically done by about 39 weeks. Nowadays, they don't typically do things electively before 39 weeks, but yeah, good point there. Stacy asks about, she turned 35. Happy birthday to you, Stacy. I don't know if that was recently, but nevertheless, belatedly so, happy birthday. She wonders about transferring 2 embryos. How do you counsel people on number of embryos to transfer?
Well, it is true that putting in more than one may up your odds of getting pregnant, delivering a baby a little bit, and sometimes a little bit more, but it also increases your risk of multiple pregnancies and twins and triplets. So under 35, we want to minimize it to 1 for the first, second, and even the third transfer, especially if they're genetically tested normal embryos. But I think that it's a consultation and counseling and discussion whether to put in 2, certainly if you failed previous cycles. But for those that are doing day 3 transfers, it may be more reasonable to do that because you are going to increase your chances of conception and delivery, but you're also going to increase your risk of multiples. And so we're really working diligently to minimize that because the risks and complications that go along with that. But that's going to be an individual question and answer between you and the practitioners that are taking care of you. And we'll discuss that at the time of an embryo transfer in many cases.
Natalie asks about her saline sonogram, says that it was worse than the HSG. Saline sonograms where we place a little straw inside the uterine cavity and place some fluid inside so we can see what the cavity looks like. And that's very important for folks who are certainly contemplating IVF, but in the fertility world in general, because we want to know that that cavity is normal. The HSG is really checking the fallopian tubes. Dr. Kiltz, for patients who are doing IVF, do they need their fallopian tubes?
Well, you don't need the fallopian tubes checked, but if you might have a hydrosalpinx, which is a blocked and dilated fallopian tube like a balloon that can be full of fluid and inflammatory material that could adversely affect the implantation, I recommended it either transected at the beginning or removed completely. So the HSG is really one of the best ways to identify that. So if you've never had the hysterosalpingogram, I would recommend it. The saline sonogram evaluates the cavity, but that might be the place to do a hysteroscopy and an endometrial biopsy D&C to further evaluate the cavity for polyps, small fibroids, scar tissue, and even looking for inflammation that could be identified a little bit better with that procedure. But the hysterosalpingogram, if it's normal, increases your chance of success, especially if you use oil contrast versus water contrast. But even with the water, it does help. But I think it is an important thing that you've had it at some point, but it doesn't need to be repeated every year. And we really need to talk to our team about, hey, I've had this, I'm fine. Let's just get you moving forward in your next treatment.
Hi, Peachy. Nice to see you. Thanks for being here with us. And thanks everybody for joining us today. We're talking about just general fertility kinds of questions, except for one important thing that I saw back there a little bit. How do we buy your pottery?
Oh, Etsy. So let's see. There is some up in the back there, which you can't see. But if you go to Etsy, I don't know if it's Dr. Rob Kiltz or Pottery Doctor or something. I don't know, but you can find some of my pots there. And it's my de-stressor. It's my rest and relax thing that I do, because I really believe that we need to be more creative, either play the piano, guitar, write poetry, do videos, do something that's creative to reduce stress. Check out my Etsy account.
And the pottery is good stuff too.
God bless.
Yes,
Thank you.
By the way, Mariella is taking metformin for her PCOS. How do you feel about metformin, and what are your thoughts about insulin resistance to begin with?
Well, number one, I don't believe that insulin resistance even exists. My theory is, since we have a tremendous amount of carbohydrates in the belly, we're always secreting glucose into the bloodstream and the liver. So that means insulin is always high. That's why fasting is really critical. So I eat one meal a day at night. If you go more than one day, it may be better, especially if you're really inflamed, but it really is important. But I'm not a big fan of metformin, maybe 500 milligrams a day at most. We're not treating diabetes. We're treating a hyperglycemic environment. One meal a day, one snack, and make it Kiltz's keto. Really important. It's high fat. And add a little bit of metformin, maybe but try the inositol or the ovasitol, which can also be very helpful. But the high fat, low carb, low protein, and one meal a day is, I think, the most important thing to do. And one is insulin resistance absolutely does not exist. And we never utilize sugar for energy. It's always fat.
Inositol is a good thing to talk about because many folks are looking for more natural ways to be able to take care of their bodies. What is inositol and where do we get it?
Well, we sell the inositol, I think, on our website, and you have to check. We have the molecular fertility supplements. We are coming out with our own inositol, but it's a natural way to reduce glucose concentrations in your body. But for me, it's still the best thing you can do is change your dietary habits, which is going to do far better. And in the long run, it's a better way to do it.
Hey, Misty had a cycle canceled because she had ovulated. And boy, that's really frustrating after you've done all the medications and gotten to that point only to find out that your ovary has released an egg. But we use medication to try to prevent that. How does that happen sometimes?
Well, the medications we use to prevent ovulation, like Lupron, Cetrotide, Ganirelix, don't always work, although they're supposed to. And so sometimes you ovulate. Now, if you're doing an IVF retrieval, even if you ovulate, we still can get good, healthy eggs out of that and make embryos, and then do a transfer that's frozen. But it does happen. If you're doing a frozen embryo transfer, we typically just use estrogen. We might use some letrozole, but there's a small chance that we can miss the ovulation time. So it's just something that unfortunately happens sometimes, and we're doing our very best to monitor it a little more carefully and give you these medications. Sometimes you have to double up on Cetrotide, double up on Lupron, or add a little bit more, by the way.
Hey, let's talk back there again about PCOS and just one more little good one there about metformin. So metformin is a drug that we use, was developed to treat diabetes. And the question was from Christy, with PCOS but normal blood sugar, is metformin still recommended? So most people with PCOS probably do have normal blood sugar. What's metformin even do in that scenario?
Well, we've misidentified normal blood sugar. We have a normal blood sugar for eating 3 carbohydrate high meals a day. We don't call it diabetes until you get to levels that are higher. My personal belief is that if you have any disease, the first thing to look at is a hyperglycemic environment that is actually in the normal range. We just misinterpret it. My belief is that because you eat 3 meals a day, your glucose level is always higher. If you only ate 1, your glucose level would be lower. You'd eliminate PCOS, you'd eliminate prediabetes, and in most cases, you'd also eliminate the infertility related to all of that, I believe. So that's why the Fertile Feast and Kiltz's Keto has a lot of really great information on Amazon. And Sam Goldman, thank you, Sam, for mentioning etsy.com/shop/Kiltz Cups. But thank you.
Kiltz Cups. Good one, Sam. Thank you for that. Amy is asking about PGT testing, and that's a big topic. It's something that we spend a lot of time on the phone discussing with people. And PGT is, of course, pre-implantation genetic. Terminology has changed a little bit, but testing, what is that, and how do you recommend patients approach it?
Well, the pre-implantation genetic screening is taking a biopsy of the placental cells and identifying if they're normal or abnormal. It's not 100% accurate, and the embryo may either correct itself or it was just the wrong information. If you have a known genetic disorder, cystic fibrosis or sickle cell or other genetic disorders that we know you have, we can identify those more accurately. But these random chromosomal abnormalities, I think, are less of a factor. Personally, I think a lot of inflammation that affects the egg and the sperm and the embryo is really the culprit. And I've seen normal embryos miscarry and become an abnormal miscarriage tissue. And I've seen abnormal embryos transfer to the uterus and become a normal pregnancy. So I just have a little bit of leeriness of the test overall. I think you must go to blast. Some people don't make blasts, and consequently, we never know what they have. But I still believe that the leading cause of all infertility and miscarriages and failed implantation is inflammation. And as we focus on reducing inflammation, we'll also increase the number of normal embryos that implant and go on to term.
Destiny, if I'm pronouncing your name correctly, is asking about tubal ligation. She had a tubal ligation, and it's something that many folks do when they decide that they are done with their childbearing. But sometimes those decisions change. There's different ways that people can do a tubal ligation as a gynecologic surgeon. Sometimes we can place a little clamp on the tube, and basically what that does is that it creates a roadblock so that sperm can't meet egg. Sometimes we'll take a piece of the tube out, and sometimes we'll take the entire fallopian tube. And so it really depends on the surgeon's preference and what things look like when they get inside to know what type of surgery you had. But tubes can be put back together, can't they? In fact, that's something that Dr. Kiltz enjoys doing very much.
So number one is I highly disagree with removing the fallopian tube for a tubal ligation, because we're seeing so many women that eventually change their mind and they only can do IVF. If there's a significant family history of ovarian cancer, then it might be reasonable. But either the clamp or the banding or removing a small segment, we typically can reverse those quite easily with a laparoscopic procedure that we do in the office. Takes about an hour. But you can get a copy of your operative report, get it from the hospital or your doctor, and take a look at it, and we'd be glad to help you with that.
And just one follow-up to that. He mentioned if there's a strong family history of ovarian cancer, and you say, wait a minute, the ovaries are the ovaries. What do the fallopian tubes have to do with that? Well, early ovarian cancer is thought to originate within the fallopian tube. So with a strong family history of ovarian cancer, there may be a good argument to go ahead and remove the tube if you're having a tubal ligation. Let's see what else we got here. Oh, Stephanie Taylor Fink. I'm familiar with her work. She gave me 3 beautiful children. Hi,
Hey,
Stephanie. That's P.S. That's my wife, in case anybody wondered about that.
How about Samantha?
Samantha, what'd you say there, Samantha? Been struggling for years due to multiple factors. Currently pregnant. And congratulations. And you've been put on bed rest due to an incompetent cervix and also adenomyosis. So the incompetent cervix, what would you like to say?
Well, that's still all intraabdominal pelvic inflammation, intravascular inflammation, which is the single cause of all of our problems. The tissue loses its strength, and so the cervix becomes more able to open up naturally. This is where that cerclage should be placed early on, and in some cases before you're pregnant, through a transabdominal procedure. But again, adenomyosis and infertility are all related to intraabdominal pelvic inflammation that damages every single nook and cranny of our bodies. So I personally, again, the young lady I talked to today that did keto, got pregnant, and then went off of it, we really need to be careful that, in my opinion, Kiltz's keto lifestyle is for throughout your pregnancy and even beyond. I think it's extremely helpful for everyone.
Hey, great question here from Erica, because one of the things that is sort of nearest and dearest to my heart, and that I think separates CNY fertility from many others, is the focus that we have on inflammation. And Erica's question is, starting prednisone during stimulation and the immune suppression protocols that we have here. When do you typically start them? And maybe just tell us a little bit about those immune protocols and the logic behind them.
Well, so as a reproductive endocrinologist, we never really talked about inflammation or the immune system as a cause. We were looking for blocked tubes, bad sperm, bad eggs, no periods. But we never really got down to the nitty gritty of the cause of all those problems. And as I began to dig deep and learn more about inflammation on a global scale throughout our bodies, I realized that what do you treat if you have upper respiratory problems? Well, I took antihistamines. We would take aspirin for inflammation. We take steroids for inflammation. So we're using these things for all other diseases. And I was like, well, maybe we should be a little bit more consistent in looking at infertility as just another inflammatory condition where we use things like low-dose steroids, we use antibiotics, we use aspirin. We use things like heparin or Lovenox, which reduces the blood clotting nature related to inflammation, which blocks the vessels feeding the fetus in the placenta and the uterus. So these are all basic components of treating inflammation. Then I learned about intralipids, which is basically an infusion of fat. Well, we learned that by eating a high-fat ketogenic lifestyle diet, you reduced inflammation. Oh my gosh, this was really amazing things. And then we got all the way to the IVIG, Humira, Cimzia, and recognizing that MS and so many other diseases are treated with these drugs. We need to look more carefully. And the more we've done that, the more we've seen success, even naturally. So the level 1 is simply low-dose steroids and antibiotic aspirin and the keto diet. Level 2 adds the Lovenox and the intralipids. Level 3, that's where we add higher doses of prednisone, 10 twice a day. We go up on the Lovenox, and we add things like Plaquenil, Prograf, Neupogen as other treatments. And then the level 4 is where we add intravenous immunoglobulins, Humira. And I think it's important to start at the beginning of the cycle, if not earlier, month 2 or 3. Now, we're generally not throwing all these drugs for 1, 2, or 3 months because steroids and these things aren't fun. So we're kind of usually limiting them to the time where you're getting close to either a retrieval or a transfer. But these things can all be used for intercourse cycles and IUI cycles alike.
How about something simple like a yeast infection? Cheryl Lynn asks, can a yeast infection or simple vaginitis affect an implantation?
Well, I was watching some videos on mushrooms, and basically the yeast and fungi and molds are everywhere. And inflammation in the vagina affects the intraabdominal pelvic environment, but it also affects the sperm as it's deposited in the vagina. It's going to get into the cervix and the uterus, and these yeast can colonize and be very difficult to treat. That's one of the reasons we recommend ketogenic diet, which again is high fat. We recommend things like diflucan. We do an antimicrobial protocol, which is kind of big guns, but it's 30 days of Levaquin, Flagyl, Valtrex, and diflucan. But again, it seems ridiculous, but I've just seen the changes. And I think when you have these bacterial or yeast infections or eczema, psoriasis, it's all related to the microbes that basically own us in some way. So when the environment has a change in pH, when there's too much of a glycated sugar environment, that's going to allow the bacteria, yeast, and viruses to get a foothold. That's why COVID virus is so deadly for people who have metabolic disorders, because they're highly inflamed.
Are there vitamins that can help with implantation?
So the molecular fertility supplements and the fat soluble vitamins, vitamin D, A, D, E, and K are critical, I think. And so, it's eat the fat, eat eggs, eat cream, eat butter, and organ meats, I think, are really good, or bone broth is really good. Now, if you're a vegan, then this is where you want to add the hemp seed oil or coconut oil will help a lot. But you got to be really careful about, there's a lot of inflammatory particles in plants that we just have to cook them well, soak them well, and add the fat, I think, is really important.
It's a great question here from Natasha that's sort of more of a 10,000 foot overview. And that is, does pregnancy via IVF give you more complications than, we'll call it, other pregnancies or by natural cycle?
Well, in and of itself, it appears so, because the majority of people that do IVF have a condition that require them to do fertility treatments. So in general, those patients have more hypertension, diabetes, preterm labor, preeclampsia, and I'll go down the list. So it's not the IVF, but it's the people that require the IVF are using it because they have more problems than we know. And they're all related to inflammation.
And so, yeah, really what that likely means, I think the data is pretty good, that if you tease out the pre-existing issues that have caused people difficulty getting pregnant, pregnancy. So
Let's see. COVID. Let's see. April asked about COVID testing. It's still required to do your retrievals. I'm hoping to eliminate that soon in New York, at least. Currently not in our Colorado office. So a very good question. And full fat yogurt is not full fat yogurt. It's made generally from whole milk and not cream. And so my bet is I don't personally like yogurt because I think it's mostly sugar. I'm not a big fan of it. If you're going to eat it infrequently or once a day at the most.
Let's see. There was one up here that caught my eye. Actually, it's kind of going back to the business about fallopian tubes. This comes from Gabrielle, and it's asking about kind of the process from of tubal reanastomosis. That's the surgery we call it. And there was a question earlier that also asked about different things that we can do to the end part of the tube, which is called the fimbria, either a fimbrioplasty or a neosalpingostomy, and that means creating a new opening in the fallopian tube. How do you feel, Dr. Kiltz, about tubal surgery for fertility as opposed to just going directly to IVF?
Well, if you have significant damage to the fimbria, the repair is not very good. And you have to think about the very, very sensitive finger-like projections of the fimbria and the tubal tissue. When it's damaged, it doesn't function right. We have to think microscopically in all of this. And so if you have a very narrow and blocked tube and you can't see any normal fimbria, you should remove the tube and go right to IVF. But if you're younger and it's not that bad, I do still recommend tubal surgery as a reasonable approach. But if you're going to do it and then wait a long time, I don't recommend that, because the younger you are, the better your eggs are. And I think moving on to IVF earlier is generally better approach. But I fixed fallopian tubes and seen success. And removing a bad tube where there's another good tube on the other side, I see pregnancies all the time, because it harbors the inflammation that is the leading cause of all the damage and disease and the infertility, in my opinion.
Do you feel like your model here at CNY has changed the way people can look at tubal disease? Because previously, when the only option for many people was to try to have surgery to correct or to address a damaged tube, because IVF was just priced too far out of the ballpark. Have we changed the way people look at that now?
Well, the biggest problem with IVF is that it's too expensive around the United States and around the world. And so we have committed to this, and I committed to this when I started this 20 plus years ago, almost 25 years ago, that I was going to make it affordable. I went into medicine to be a doctor to help people, and I continue to focus on that model. So but we don't just do IVF. We really focus on the global approach to your health and wellness, to the female side and the male side, the best eggs, the best sperm, the best embryo, and the best environment for implantation. We're seeing so much endometriosis, so much metabolic and PCOS, and so many fibroids that I really believe our biggest issue is still the inflammation. And that's the other part that we've really focused on, is how can we help you gain the knowledge without ever coming to us that might get you pregnancy and delivery.
Hey, Christy asks about Hashimoto's. And if you're not familiar with the term, it's a scary sounding term, Hashimoto's. But Hashimoto's is an autoimmune response against your own thyroid, what we call autoimmune thyroiditis. Now, how important are thyroid levels in the whole IVF process?
Well, in my opinion, all inflammation is due to a foreign particle that gets in our body, and we elicit an immune reaction because of that. So, in fact, our bodies are really not reacting against us. It's trying to protect us. That's the same thing like the COVID virus. So I don't believe in autoimmune causes. We have inflammatory processes due to foreign particles that get into our body, either breathing, drinking, eating, or getting in some other way. And there's a lot of ways that this stuff gets in, because we're just like every other a particle of the universe. Someone wants to eat us. They use us for their lifespan, and we're doing the same thing. But Hashimoto's thyroiditis is one of the most common and most sensitive organs, the thyroid gland. And thyroiditis can be high thyroid hormone levels or low thyroid hormone levels. And it may end up with a surgical removal or radiation even. And it can end up in cancer because of chronic or acute inflammation.
Well, how important is the thyroid to the IVF process?
Well, the thyroid gland is critical for our life functions, and fertility in IVF is very critical. It seems to be much more critical if you have a low thyroid hormone. So if your TSH is high, above 2.5 we look at, but really normal high might be above 5, then you need to look at your thyroid hormones, T3, T4, and look at thyroid antibodies to kind of get a sense of, is my thyroid really working well? Plus iodine. Iodine, by the way, is mostly in meat and not mostly in plants. So when we eat a mostly plant-based diet, we're missing the iodine. That's why it's critical to have iodine in the salt. And we're told not to eat salt, which is another problem in my opinion, but my diet includes salt and I think it's important. But the thyroid gland is something we work to follow carefully because quite often, because of the treatments, the thyroid gland goes all over the place. Again, stress, but there's also some confounding factors based on the testing of these hormones that may not always be 100% accurate. But if your T3, T4 are in normal levels, even if your TSH is a little higher, a little low, then you're okay, but we still are going to work to adjust it and try to keep it in that sweet spot.
By the way, he said something about just a minute ago. Do you know what he meant when he was talking about COVID? That it's our body's response to COVID. It's not the COVID itself. Do you understand what that means? Tell him what that means.
Well,
how does COVID affect us?
So if we're in any way inflamed and a little bit more susceptible to foreign particles, and COVID virus is just another glycoproteinaceous particle that gets into our body, and it breaks through the glycocalyx, which is the protective layer in every epithelial cell line. But it basically it stimulates an immune response, which could be a little bit. You can't smell or taste, or you suddenly have difficulty breathing, or you feel fluish, or all the way to obviously organ failure and death. So all these things are, I think, critical, and COVID is just one microorganism that's a factor in all this. If you look at the plant antigens and the phytochemicals and the microscopic organisms, all of these things elicit a very similar reaction in our bodies that modern medicine says idiopathic, and we don't know what it is, but it really is very simple. Our diets are absolutely the single leading cause of all of our problems, and our healthy diet is incorrect.
Some folks are asking about Omnitrope, which is something that we use. Tell us what Omnitrope is.
So Omnitrope, human growth hormone, is another one of those hormones that we found may help improve sperm and eggs and the environment for implantation. So we use them both on men and women, mostly women, to improve the egg quality, whether you're young or medium or older. Again, it's all relative, and I think we're all young, by the way. But the Omnitrope may be helpful to improve your egg, sperm, ultimate embryo, and thus implantation. So we're beginning to talk more and more about using the Omnitrope, lower doses of 3 units for priming and 6 units in stim, but even for frozen transfers, using it more and more. So you have to ask about it. Typically, we're using the human growth hormone or Omnitrope for diminished ovarian function or limited egg reserve or bad quality eggs. But we're using it a little bit more globally, like low-dose naltrexone and CBD oil and keto. But important to know that some people will use these things that we think are good for most people, but they don't improve, or they may harm a little bit. So just be cognizant of everything we put on the table. We're hoping it's mostly beneficial, but in some rare cases, it may not be may not be improving, or it may be harming a little bit.
And Stacy asked about using it for a couple of months before the cycle. So in the wellness community and in the anti-aging community, we use growth hormone and growth hormone secretagogues, which is something that causes your body to make more growth hormone on an ongoing basis. So no issues there. And there was also a question about does the COVID vaccine affect sperm count? And the answer to that would be there's no evidence that it does.
Well, I'm going to say we just don't know a lot of these questions. And obviously, would you rather have the COVID virus or the COVID vaccine? And, there's a lot of things that we just don't know enough about. But in general, I would say we're recommending the vaccine. But, should you give yourself some time between the vaccine and conception, maybe a couple of weeks, maybe a month or two? No one knows that absolutely.
Can you get the vaccine when you're on Omnitrope? The answer is yes. Good. Maybe you want to address Sienna's question there. She had a follow-up with me, but somehow or another it was canceled. So my gosh, I'm so sorry. I'm sorry to hear that. Curious about the take on implantation. So Sienna's had 3 transfers. Nothing has worked yet. And she feels frustrated about what's the next step in her process.
Well, Sienna, do me a favor. Send an email to rkiltz@cnyfertility.com. We'll take a look at that. I apologize. We've had a little bit of shifting and changing team members a little bit, and sometimes this happened, but we're going to do our very best to get all of this answered for you. But, dig deep and go to Amazon. We have our new family building guide is there. Kiltz's keto lifestyle is there, and also the Fertile Feast is there. So I think all of these things give a very comprehensive approach to improving your environment to help. And I'm talking a lot more about mini protocols for most everyone, the immune 3-4 protocols. Don't forget laparoscopy, hysteroscopy combined to look for endometriosis, pelvic scar tissue, or pelvic intraabdominal inflammation. I really think it's important that we all look at these things in a global approach. I recommend yoga, Tai Chi, meditation, go for a walk, get off the treadmill and slow it down. But remember, faith trumps all of it. Have faith in the higher power that's going to help you and I and all of us get to the dreams we desire, which is not so easy, I know.
Megan asks about, she's doing a day 3 fresh transfer, non-tested embryos. Is she a candidate for a 2 embryo transfer? So she's got tubal factor, her AMH is 3.1.
Well, age is a major factor. If you're under 35, the first time we recommend 1. You have tubal blockage, AMH is good, we'd recommend 1. If it doesn't work, you'll have 2 on ice. Then, and now again, that doesn't always get 2 on ice, but I would personally recommend do the 1, freeze the 2 if it's a fresh transfer, and then if it doesn't work, make sure you've covered all your checks and balances. And in the family building guide is a checklist of all the possibilities, but I do recommend the 1 and not the 2.
Let's see. We just saw a good question here. This is from Vivian about fibroids. How do you get rid of fibroids? First of all, what are fibroids? They're balls of muscle, right? Why do some people have them? Some people don't?
Well, they're abnormal growths of inflammatory tissue in the uterus or around the uterus, but technically they could grow anywhere in the body. They're 99.9% not cancerous, but to me, they're like endometriosis, a sink of inflammation. My belief is that we're all predisposed to majority of diseases we get, like endo, fibroids, PCOS, arthritis, psoriasis, diabetes, kidney stones, cancer, and hypertension. We'll go down the list. So our diet is the culprit, unfortunately. The uterus is just like a kidney or any other organ. It's a tremendous amount of microvascular systems that tends to capture all the stuff going through the blood system that basically acts like a filter. It gets lodged there. Your body reacts to it, causes localized inflammation. Now, why some people get it more than others, that's the biggest mystery. Many women have babies and don't have any problems, even though they have fibroids or endo or PCOS. But when we find these abnormalities associated with infertility, I in general recommend removing them. But there is a new device coming out now where kind of you stick a needle into the fibroid during surgery and it kind of microwaves it. Now, I have not had experience with this. It's a newer technique. I don't know that answer, but in general, we do a lot of laparoscopic myomectomies.
So I've actually been trained in a procedure that uses, you place the needle into the fibroid and it shrinks it, it freezes the fibroid and it shrinks it. There's just not great data about what are the effects on the uterus as it pertains to pregnancy afterwards, but at least it's giving us more options in the ability to treat fibroids. Now, but fibroids themselves are not necessarily problematic, right? 70% of women have uterine fibroids. When do they become problems? And why would a woman say, oh, I have fibroids and now I have to worry?
Well, we don't want you to worry. We want you to work on having faith and believing in the wonder of the things happening. If you haven't read my book, The Fertile Secret, which talks about how we need to emulate a more positive, visualize that things that we want. But it is frustrating and can be really hard. These fibroids, sometimes you take them out and they pop back up. In my opinion, it's still because whatever we're doing has a highly inflammatory environment, and it's not always so simple. But in some cases, this is where we recommend looking at a gestational carrier to carry your pregnancies if we just can't get rid of it. But one other option is a couple of months of Orilissa and letrozole, which treats adenomyosis, endometriosis, and may also help treat uterine fibroids in some way that may help get your uterus a little better shape if you can't or have been unable to remove all the fibroids.
Now, as a general rule, the fibroids that are inside the uterine cavity, which we call submucosal fibroids, those need to go. And that's usually a simple outpatient procedure that we do through a little camera that goes into the uterine cavity called a hysteroscope. And so that myomectomy through the hysteroscope, as I said, just takes a few minutes. In fact, I think Dr. Kiltz did today, or yours laparoscopic today?
I did 3 laparoscopic. I did one little small hysteroscopic fibroid, but in general, if they're easily removed hysteroscopically, it should be done. Some cases you can't easily remove them hysteroscopically, and you need to do a laparoscopy or sometimes a laparotomy where you open up the abdomen a little larger. But there definitely can be a factor in reducing natural pregnancy, IUI, and in vitro fertilization.
Teresa has a question here, pretty specific about herself. Her AMH, which is the ovarian reserve marker, is 0.4, and she's 31 years old. So that's a little lower than I would expect for most 31-year-olds. She has no left ovary, no fallopian tube. She has endometriosis and PCOS. Can she still use her own eggs?
Absolutely, yes. So the lower AMHs is a marker of your reserve. It doesn't necessarily say your eggs are good or bad. The younger you are with a low AMH still boasts a little better odds than if you're older with a low AMH. But again, the cause of a low AMH is inflammation. The cause of PCOS and endometriosis and infertility is inflammation. By looking at Kiltz's Keto Lifestyle and the Fertile Feast, you'll get a lot of really great information. Go to Amazon, download them, or get a paper copy. But tell me what you think. Write your reviews that'll really help us how we can better share the next story. But I've seen AMHs go up. Obviously, they removed, and today I removed fibroids and scar tissue in a tube in someone who had a previous left tube and over removed for bad endometriosis. And so they just recur because we're not being given the absolute truth of the cause of these things, which is a healthy lifestyle, as we've been led to believe incorrectly, in my opinion, experience. And 65 tomorrow, by the way. And I stopped exercising 10 years ago. I stopped eating fruits, fiber, vegetables of any significance 10 years ago. And I really worked to eat that one meal. I personally eat a ribeye steak, but if you're a vegan, vegetarian, Mediterranean, or pescatarian, it can be done. So look at our Fertile Feast and the Kiltz's Keto Lifestyle. But don't believe me, by the way. But if what you're doing isn't working, why not do something really radical and amazing? Because you deserve it, and you're the most valuable, expensive, and irreplaceable being of the universe, in my opinion.
And let me tell you, this guy has never had a bad hair day, ever. Never.
I
had
do
a
cut
bad-
my own hair, by the way.
Oh,
So, that's the beauty of it. And this is the real color. My grandmother had white hair like at 40, and I was close.
very distinguished, very distinguished. Hey, CNY Nation, we're happy to have you with us today. Conversations with Kiltz and Fink. It's about 45 minutes after the hour, and we'll only keep you for another 15 minutes or so, but let's see if we can get some more questions in here. Ashley, we're glad to have you as part of the CNY family and considering being a travel patient, but you're wondering about your husband coming. The schedule may not be as flexible, and that's often the case. Two people having differing schedules, can semen or sperm be frozen?
So one is to go to a local clinic that freezes sperm and ship it, or we have an overnight package that we'll send to you. You'll provide the sample into the cup, seal it, package it back up, and overnight ship it to us. And 95% of the time we get good quality sperm back that we freeze and can be utilized for an IVF or even an IUI cycle. But we also have our centers between Atlanta and Colorado, soon to have our Sarasota and Miami office. Really excited about those. Also, with Dr. Ivanova in Philadelphia, we put a satellite that's going to really help a lot. But look and talk to us. We'll be glad to help get that. And even in some cases, you can bring the sample yourself if you're coming overnight. I don't know. You always be careful about what the airplane TSA is going to say, but
it's a hard one to explain to TSA. Maybe,
but
right?
We've had them. They're very, very helpful. If you're coming to a CNY fertility location around the country, and they're really doing their darndest. And even the Canadian Border Patrol has been very good. As long as you have a letter, and we'll get you a letter that says this is what this is for, and it'll be very helpful. But we're all very busy.
And the answer is yes. So there's a way. There is definitely a way. Lena's got a good question there about her COVID vaccine. She's starting her antimicrobial protocol before she is to get her second COVID shot. What's your recommendation on that?
I think you're okay with that one personally. I mean, the COVID vaccine is added to create more antibodies to prevent the virus infection. I think that still taking the antimicrobial protocol is helping you for the treatment we're doing here, and I don't see any reason that you can't do both.
Philadelphia, you mentioned. When's that coming online?
Well, the Philadelphia location for monitoring blood draws and ultrasound is really online today. We're getting more information out over the next couple of weeks, but we're working on our training our team there, but it'll make it so much easier for those in Philadelphia to get a consultation with one of us over either video or telephone, and then go in to get your baseline ultrasound, your blood work, your monitoring, and then come to one of our locations in upstate New York, Buffalo, Syracuse, or Albany for your actual egg retrieval. And then we will be doing IVF later in the year in Atlanta, Sarasota, in addition.
Exciting times, exciting times. Is IVF possible with fibroids? And the answer is yes. One of the things that we do in the evaluation is we want to know about the uterus. We want to know sort of how things look on the inside. And so if we find fibroids that are inside the cavity, that's something that we typically want to address before IVF because they may be taking up valuable real estate on the inside. But fibroids are not a contraindication to IVF.
And if the fibroids are in the 1 to 2 centimeter range, they're not abutting into the cavity at all, and preferably they're not even butting next to the cavity, but far away, I don't think it's a big issue. But again, if I see fibroids, I know there's inflammation in your abdominal pelvic cavity. And quite often we see scar tissue, we see endometriosis at the same time. So I think it should be addressed.
We've got a question here. It's really kind of an obstetric question that comes from Samantha. We started off. I think we addressed the first half of your question before, but I think there was another half of it. You have an incompetent cervix, and and are on bed rest as a result of that. You're wondering about mode of delivery, C-section versus vaginal delivery, with concern that a vaginal delivery may further damage your cervix. Well, one of the questions I would have is, I'm presuming, do you have a cerclage now? A cerclage is a stitch that goes in the cervix for people who have an issue where the cervix can't keep itself closed. If you have a cerclage, odds are you have a cerclage for this pregnancy, you will have a cerclage for subsequent pregnancies. But any thoughts about mode of delivery in terms of further scarring on the cervix?
Well, if the plan, in general, removing the cervical cerclage in the lower and the vaginal region is common to do. You're going to remove it anyway. And then if you go into labor, allow normal labor and delivery. But if you have a transabdominal cerclage, then you're going to get a cesarean section. But I think you should be able to do that.
Belair asks about the thickness of the lining. This is something we talk about a lot, and we talk about this so much, we just assume that everybody knows what we're talking about. So the uterus is a big muscle, and the muscle's job is to hold the baby and to squeeze that baby out when the time comes. Fibroids are balls of muscle in that within that muscular organ, but the inside lining of the uterus is the glandular portion, right? That makes a nice spongy warm place for a baby to implant. In the IVF and in the fertility process, we look at that lining and we measure that lining. And sometimes we say, oh, that lining is thin. And then sometimes we say, oh, that lining is thick. What's a thick lining?
Well, Donna Mack, thank you very much. And hello to everyone, by the way. And thank you for all the shout outs. We really appreciate you guys joining us. We're going to continue our lives on Thursday at 4 p.m. Eastern time. I do a Sunday live at 10 a.m. Eastern time. And I've been doing it for a few years now, and always grateful to be having so many join me. But we don't really know a too thick lining. I've seen papers in the 17 to 18 millimeter range that seem to be higher, but if it's going greater than that, we're probably saying it's too thick. Too thin is less than 7 millimeters. There was one question earlier about a homogeneous versus a triple lining. We're typically looking for the triple lining. The homogeneous is where you can't see the different layers, which in general, you should sort of see the central layer line, which calls it triple line. But there are people who have babies with the homogeneous and those that don't with the triple lining. But we're typically looking for the 7 and above and the 18 and below range. But I know we freak out if it's over 13 to 14 millimeters. But again, if it's getting thicker, it may be a much better vascular environment for implantation. But again, we're doing more and more with those thicker linings, and I think they work out nicely.
Now, how does that differ if a patient's coming in for her initial evaluation and you find, gosh, that lining looks really thick? What does it make you think?
If it's really thick, you want to be concerned, especially if it's homogeneous and you can't really tell. There might be a small polyp or a small fibroid in the way. This is where the hysteroscopy, saline sonogram, or hysterosalpingogram. And what we work to do in our office is do the hysterosalpingogram with an ultrasound to do a saline sonogram at the same time, which I think can really help tremendously.
April asks about her husband and collecting his sample at home and bringing it in compared to doing it in the office. That's, of course, an option, yeah?
Yeah, absolutely. We don't need it in the 2-hour range. And having ejaculations every day may actually improve sperm. And for guys, the molecular fertility male plus Kiltz's keto, LDN, and slow it down too.
All right. Brittany's asking about how are protocols tailored to individual patients. And I would say the first thing is maybe what she's asking about, how is it that one size doesn't fit all? How are individuals handled?
Well, we want to know about your story. But really, if you look at fertility or any diagnostic diseases in medicine, there are typical treatments for certain. But if you've had a tubal ligation, you may not have the same immunologic problems. The younger you are, a lower dose protocol. But we've moved those that are that are in the late 30s and 40s with the lower AMHs to the lower protocols also. So we're kind of it's always adjusting, and we're going to talk to you about our protocols individually, but really we have an amazing team. We found some sweet spots. For me, it's mini protocol. It's going to be the immune 2 or 3 protocols. It's going to be Kiltz's keto lifestyle. It's going to be acupuncture, massage, meditation. Check out our Fertile Spirit, where we're offering a counseling group to help individuals or groups. Very helpful. So, in fact, that we're talking similar things because really it's a similar process that we're sharing in this. But we're always open to what you want to bring to the table. Whether you do inflammatory protocol 1, 2, 3, or 4, whether you do a laparoscopy, hysteroscopy or not, we have a menu of options that in our family building guide can be very helpful.
We talked a little bit about intralipids before. When Jody asks, do intralipids come into play? What's the timing on use of intralipid?
Well, so the intralipids are an infusion of fat. That's why we recommend eating fat, because it reduces inflammation. So at least by transfer or by IUI or by intercourse, but if you do it a week ahead of time or even 2 weeks, but I'd say the week ahead of time with your transfer, and then weekly through the first trimester, I think can be very helpful.
Barbara Jean, glad to have you with us, and you're doing donor egg, which is a great thing. Good. We're very happy to hear. What are the meds? What's the donor egg process like?
So donor eggs are using eggs from another woman, whether it's a relative, a friend, other family members, or in our case, it might be a stranger through an egg bank, through CMI Fertility Egg Bank or other egg banks around the country and the world. But basically, we make an embryo and freeze it with your partner sperm or donor sperm, your choice, whatever your issue is. And then we grow that embryo to either the day 3 stage or the blast stage, 5, 6, or 7. You may or may not choose to do genetic testing or PGS testing or gender testing, which can be done. But then once we have the embryo, we'll get your body ready for transfer by either a natural cycle, minimal medications, or estrogen. But this is where we look at things like inflammation, other comorbidities, or other medical issues going on, where we want to focus on things like laparoscopy, hysteroscopy, and which immune protocol that we want to use for you.
Could interstitial cystitis with pain be a concern for pregnancy? Well, I can guess Dr. Kiltz is going to say interstitial cystitis is a sign of
inflammation. Wow.
And what happens with inflammation? It stands in the way of a lot of things. And so could it be an indicator of other issues? Yes, it could. Hey, gosh, here's funny. Somebody just asked, that's Lauren. Did I hear wrong? Did you say slow down the exercise?
Absolutely slow down. Now, I'm going to let my neighbor drive my Ferrari, which I don't own one, but if you did, right, you're not going to let your neighbor take you to the racetrack 3 days a week. It's absolutely untrue that exercise 3 to 6 times a week is good for you, in my opinion. Slow it down and cool it down. The more you exercise, the more you heat up the core. You heat up the core, you damage your DNA, both sperm and eggs and embryos. Personally, I stopped nearly 10 years ago. Game change. All my joint problems, back problems went away. I've never felt better. And when I eat the proper diet for the human Ferrari, it's amazing. So look at my Fertile Feast and Dr. Kiltz's keto lifestyle, get a lot more information, but I'm betting $1 billion on this one.
And one of the reasons I like the guy is because he told me I don't have to exercise. I mean, how can you go wrong with that? He also told me I could eat donuts.
Well, once in a while.
Well, and that's an important
all
thing.
The time.
Right, but you're allowed to
reward yourself.
You're allowed to reward, right? It's not cheating, it's rewarding.
Absolutely. And if you're going to go for a bike ride or do something, but I do know there's a lot of tremendous injury and damage from too much exercise. But the things that we talk about, it really is a life-changing experience, and we are worth it. all of us, we look in the mirror and God is there. We have to have faith in this higher power. And we're learning something radically new that I didn't believe 10 years ago. And I certainly, as a medical student and resident and fellow and a researcher, didn't believe much of what I'm telling you. But I bet that this is the home run.
Yeah. I think he's really onto something here. And actually, Becky Ann asked that question. If I want to do that immune protocol, if you're being treated here, immune protocol is part of our treatment.
Couple of quick questions here. Isabel asked about intralipids up to 14 weeks weekly, that's into the second trimester, maybe every 2 weeks, and up to term monthly. IVIG is another one, weekly to every other week till about 14 weeks, and then monthly to term, because these are the game-changing things that you might need. We work with Quack Chem, but we are reproductive immunologists. We focus on immunology. My belief is that the blood test don't tell us which drug you need. So if what you're doing isn't working, like IVF, you're having sex, or IUI not working, you go to IVF, it's very expensive. The immune treatments fall into the same thing. Go to a little bit more aggressive, a little bit more expensive, but they can work for you. So don't close the door on those things.
Well, CNY Nation, it's about top of the hour here. So glad to have you with us today. What a great group of questions, great group of people. We really appreciate it. Thursday afternoons with Kiltz and Fink. And Dr. Kiltz has his Sunday morning house call. What time is that?
Let's see. Sunday?
I don't you do Sunday.
A Sunday morning at 10 a.m. Eastern time. I'll see you then. Facebook, Instagram, and YouTube. And check us out on TikTok. And we're sharing some ideas about endometriosis and fibroids and tubal ligations and your health and wellness tips. So we're really excited about putting more and more out there.
And last thing to say, aside from thanks for being here, happy birthday, Kiltz.
God bless you guys. Thank you. And happy birthday to everyone out there. God bless you.